Good morning, everybody.
The
brave / revisited. Spontaneous detachment of the Descemet's membrane of the graft following a penetrating keratoplasty is a rare entity. A large or subtotal DMD of the graft can be difficult to manage and may fail despite multiple attempts. We report a technique of draining the pre-descemetic fluid with the help of a venting incision to achieve successful descemetopexy with gas. So the premise, a 29-year-old male diagnosed with bilateral pellucid marginal degeneration suffered acute hydrops in 1992. He underwent a right eye penetrating keratoplasty in 93 and maintained a clear graft, no episode of rejection, and BCVA of 612 till 2019. But in October 2019, he presented with right eye sudden onset fall in vision to counting fingers at 1 meter. Initially, the premise, it looked like an acute graft rejection, and even a pigment line was seen mimicking a Kodadas line. The left eye had a PMD. But something was amiss. When we saw the patient, there was, on diffuse illumination of the right eye, showed edema of the corneal graft, sparing only the inferonasal 1/3. So when we deturges the cornea with sterile topical glycerine, as the white arrow shows in figure A, it shows the junction of the attached and detached Descemet's membrane of the graft. The slit image clearly demonstrates the same. So the AIOC also was corroborative, horizontal and vertical images showing the Descemet's membrane detachment. The left eye was showing advanced PMD. So what we did in this case, this patient presented to us 10 weeks after initial loss of vision. So because it was a long duration, we performed a supradescemetic venting incision after debriding the epithelium in the center at the area of the maximum detachment of the DMD. And then we drained the interface fluid and attached the Descemet's membrane with 20% non-expansile SF6 gas. These are the post-operative images, the figure A on POD1, showing the arrow showing the black arrow showing the venting incision and the two arrowheads showing the demarcation line. So after POD8 also, you can see that the graft is now very well cleared as demonstrated even by the AIOC with attached DMD. So as far as literature search goes, before our case, there have been 6 cases only reporting PKP spontaneous DMD. And out of all these cases, out of the 7 cases, 6 cases have occurred only after, say, around 20 years of the initial PKP. So usually they present very late with spontaneous DMD. Now, considering time to descemetopexy, time to intervention versus success of descemetopexy, patients who presented the first 2 cases 6 and 8 weeks after the DMD happened, they had poor response to descemetopexy and the descemetopexy failed. The case 3, 4 and 5 that were intervened immediately succeeded. Case 6, despite immediate intervention, failed. Ours was the longest time to intervention, 10 weeks, but still our descemetopexy succeeded, most likely because of the venting incision that we created. So to conclude, a high index of suspicion helps us to differentiate and diagnose spontaneous graft DMD from acute graft rejection. And AIOC in this context will really be a valuable tool. And supradescemetic venting incision is a simple but significant addition to the armamentarium of management of DMD, especially long-standing ones, or those that have failed routine tamponading with gas or air. These are my references. Thank you.
What could have been the cause for the spontaneous DMD etiology?
So this is, the cause is really not known. There is no history of trauma. But the only thing that we are thinking of is that there is a fibrosis of the Descemet's membrane, and there is, these are ectatic cases. So if there is any progression of ectasia, so PMD or keratoconus, and there is a progression of ectasia of the graft, and the Descemet's membrane is contracted in the periphery, it is unable to match with the ectasia progression. That is when it detaches and happens after a very, very long period.
Progression of ectasia and possibly a hydrops kind of thing.
Hydrops, there have been cases in of hydrops occurrence, not exactly a DMD. This is DMD without clear hydrops.
Okay. So a simple stroking of the surface and draining out the fluid from the surface along with placing the air bubble, would it have helped rather than giving the venting incisions?
So these cases, now the thing is, this patient had a 10-week waiting period between the presentation and the intervention. The only thing is what happens to the quality of the supradescemetic fluid. It may change in quality. There are more proteins. From an transudate, it becomes more like an exudatish. If it is viscous, it is difficult for it to clear off. As the literature has shown, long waiting period is not helping us with regular decimatopexy, it is not helping the attachment. So that is the reason we decided to drain. That is one thing. The other thing is when these long waiting period can also cause the peripheral margins of this DMD to get fibrous. So when we are actually tamponading, and if the fluid is not getting drained through the peripheral open area of the DMD because it is fibrous, it may end up not attaching the DMD or even sometimes even worsening the DMD because there is no other area of least resistance. So that is the reason why we chose to do the simple maneuver, and we stroked the fluid out completely. So the important thing is to make the paracentesis only after making the venting incision, so that the DMD is maximally detached. You don't have any risk of puncturing the Descemet's membrane when you are doing the venting incision. And following that, you inject either gas or air as the case may be, and keep milking the fluid out. It comes out very well. I could not show the video because this is a poster presentation, but you keep milking the fluid out, and at the end of say about 10 minutes or so, all the fluid usually comes out and we can attach.
Doctor, you used air or C3F8?
In this particular case, I have used 20% sulfur hexafluoride, non-expansite.
And how much follow-up you have now on this patient?
This patient, I have 1.5 years follow-up.
And still clear?
Yeah, the graft stayed clear. Only thing is post SF6 probably, he was actually 27 years after PKP. The gas probably has induced, over 1 year he started developing lens changes and he required a cataract surgery.
Okay, thank you.